Block simulation 20. Same process, fresh set. Read the command first, scan the clues, build fast, lock and move. 20 questions, 30 minutes. Clock starts now. Compare with breathing slowly and deeply, rate 10, tidal volume 600 ml. At the same minute ventilation, what happens to alveolar ventilation and why? A patient breathes rapidly and shallowly at a rate of 30 min with a tidal volume of only 200 ml. The anatomic dead space is 100 ml. Read the command. Effect of rapid shallow versus slow deep breathing on alveolar ventilation. Rapid shallow wastes more in dead space. Why lower alveolar ventilation? The key is the difference between minute ventilation and alveolar ventilation. Minute ventilation is rate times tidal volume. Both scenarios give 6 liters per minute, but only the air reaching the alveoli does gas exchange. The dead space, the 150 ml, is wasted each breath. Alveolar ventilation equals rate times tidal volume minus dead space. For rapid shallow breathing, 30 times 200 minus 150 equals 30 times 50, which is only 1.5 liters per minute. For slow deep breathing, 10 times 600 minus 150 equals 10 times 450, which is 4.50 times more effective. The correct answer is E. The principle is that dead space is a fixed D volume per breath, so when the tidal volume is small, the dead space consumes a much larger fraction of each breath, leaving little for actual gas exchange. This is why rapid, shallow breathing is inefficient and can cause hypercapnia despite a normal-looking minute ventilation. Slow, deep breaths are far more efficient at alveolar ventilation. The greater dead space waste of rapid, shallow breathing, lowering alveolar ventilation is the answer. What is the diagnosis and the mechanism of the hypertension? A 60-year-old man with metastatic lung cancer develops acute dyspnea and hypertension. Exam: distended neck veins, elevated JVP, muffled distant heart sounds, and hypotension. There is a 15 mmHg drop in systolic BP during inspiration, pulsus paradoxus. ECG shows low voltage and electrical alternance. Read the command, diagnosis, and mechanism. Distended neck veins, muffled heart sounds, hypotension, Beck triad, pulsus paradoxus, electrical alternance, cardiac tamponade. This is cardiac tamponade, fluid. Here, a malignant effusion accumulates in the pericardial SAC, raising intrapericardial pressure and compressing the heart from outside. This compression prevents the ventricles from filling adequately during diastole, so stroke volume and cardiac output fall, causing hypertension. The classic BCK trait reflects this. Hypotension, low output, distended neck veins, elevated JVP, impaired venous return backing up, and muffled heart sounds. The fluid muffles them. The correct answer is B. 2 additional signs confirm it. Pulsus, paradoxus. An exaggerated over 10 mmHg drop in systolic blood pressure during inspiration occurs because the inspiratory increase in right heart filling bows the septum into the left ventricle in the constrained pericardium, reducing left-sided output. E. Electrical alternance. Beat-to-beat variation in QRS amplitude reflects the heart swinging in the fluid. Treatment is urgent pericardiocentesis. The pericardial fluid compressing the heart and impairing diastolic filling with Beck triad and pulsus paradoxus is cardiac tamponade. What is this disorder, and which copper-dependent enzyme's deficiency explains the connective tissue and hair findings? A male infant presents with brittle, sparse, kinky, depigmented hair, growth failure, hypertonia, and progressive neurodegeneration. The condition is X-linked. Labs show LOW serum copper and LOW ceruloplasmin. The defect is in a copper, transporting ATPase that impairs copper and sporting ATPase that impairs copper and sporting ATPase that impairs copper absorption distribution. Read the command, disorder, and which copper enzyme. Kinky hair, copper deficiency, X-linked, ATP7AA. Menkes disease, deficient lysyl oxidase. This is Menkes disease, an X-linked disorder caused by a defect in ATP7A, a copper-transporting ATPase needed for copper absorption from the gut and its distribution to tissues. The defect causes copper deficiency, low serum copper and ceruloplasmin. The key downstream effect is deficiency of copper-dependent enzymes. Most importantly, LY cell oxidase, which requires copper to cross, link collagen and elastin. Without functional lysyl cell oxidase, connective tissue is weak and elastin is defective, producing the brittle, kinky, steely hair, tortuous blood vessels, bone abnormalities, and connective tissue problems, along with neurodegeneration. The correct answer is D. The crucial contrast is with Wilson disease. Both involve copper-transporting ATPases, but Menkes is ATP7A, causing copper deficiency. Copper can't be absorbed exported, while Wilson is ATP7B, causing copper ACCU. Mutilation, copper can't be excreted in bile. Menkes may not enter deficiency. Wilson won't leave overload. The ATP7A defect causing copper deficiency and deficient lysyl oxidase with kinky hair identifies Menkes disease. What is this syndrome and which pathway is interrupted? A 55-year-old smoker presents with a drooping right eyelid, ptosis, a constricted meiotic right pupil, and decreased sweating on the right side of his face, anhidrosis. Imaging reveals a tumor at the apex of the right lung. Read the command, syndrome, and pathway. Ptosis, meiosis, anhidrosis, lung apex tumor, Horner syndrome, interrupted sympathetic pathway. This is Horner syndrome, caused by interruption of the sympathetic, oculosympathetic pathway to the head and eye. The classic triad is PTOSis, mild drooping, from loss of the sympathetically innervated malar muscle, and meiosis, constricted pupil, from loss of the pupillary dilator, and anhidrosis, decreased facial sweating. Here, the cause is a Pancoase tumor, a malignancy at the apex of the lung, which invades the nearby sympathetic chain, the stellate ganglion, interrupting the sympathetic supply to that side of the face and eye. The correct answer is D. The triad is the signature. Remember, PAM is horny, ptosis, anhidrosis, meiosis from a Horner lesion. The sympathetic pathway is a 3-neuron chain, hypothalamus to spinal cord, to the sympathetic chain stellate ganglion, to the eye, and a lesion anywhere along it causes Horner syndrome. Commonly, a Pancoase tumor, carotid dissection, or a brainstem stroke, as in Wallenberg. The ptosis, meiosis, and anhidrosis from sympathetic interruption by a lung apex Pancoase tumor is Horner syndrome. What is the diagnosis and the mechanism? A previously healthy 18-month-old boy presents with sudden episodes of severe intermittent colicky abdominal pain, drawing his legs up and vomiting. He passes stool mixed with blood and mucus described as currant jelly. A sausage-shaped mass is palpable in the right abdomen. Ultrasound shows a target or bull's eye sign. Read the command, diagnosis, and mechanism. Toddler, colicky pain, currant jelly stool, sausage mass, target sign, intussusception, telescoping bowel. This is intussusception, the most common cause of bowel obstruction in infants and toddlers. The mechanism is telescoping, one segment of bowel. The intussusceptum invaginates into the adjacent distal segment, the intussuscipiens, like a collapsing telescope, most often at the ileocecal region. This causes intermittent obstruction with colicky pain. The child draws the legs up, and as the mesentery is dragged in, the blood supply is compromised, causing bowel ischemia. The classic currant jelly stool is a mix of blood and mucus from the ischemic mucosa. The correct answer is B. The physical and imaging clues are characteristic: a sausage-shaped abdominal mass, and the target or bull's eye sign on ultrasound, concentric rings of telescope bowel. In young children, it is often idiopathic or follows a viral infection, lymphoid hyperplasia acting as a lead point. In older children, a pathologic lead point, like a Meckel diverticulum, may be present. An AIA, or contrast, enema is both diagnostic and often therapeutic, reducing the intussusception. The telescoping bowel with currant jelly stool and a target sign is intussusception. Which statement about placental pregnancy hormones is correct? A physiologist studies hormone production during pregnancy. Early pregnancy is maintained by a hormone produced by the trophoblast that rescues the corpus luteum. Later, the placenta takes over progesterone production. Read the command. Which statement is correct? HCG maintains corpus luteum. First trimester shares alpha subunit. HPL causes insulin resistance. Several pregnancy hormone facts are testable. Human chorionic gonadotropin, HCG, made by the S1 syncoid trophoblast, rescues and maintains the corpus luteum in the first trimester, so it keeps secreting progesterone to sustain the early pregnancy. HCG shares its A-alpha subunit with LH, FSH, and TSH. The beta subunit confers specificity, which is why very high HCG, as in molar pregnancy, can stimulate the thyroid. After the first trimester, the placenta takes over progesterone production, so the corpus luteum is no longer essential. Human placental lactogen HPL is diabetogenic. It promotes maternal high insulin resistance to shunt glucose to the fetus, contributing to gestational diabetes. The correct answer is A. The functional logic progesterone maintains the pregnancy and keeps the uterus quiescent. It relaxes the myometrium, the opposite of causing contractions. Estrogen is produced by the placenta using fetal and maternal precursors, growing the uterus and breasts. HPL raising maternal insulin resistance to favor fetal glucose supply is the basis of gestational diabetes. The HCG corpus luteum rescue, shared alpha subunit, and HPL insulin resistance are the correct statements. Which pairing of insulin and onset duration is correct? A patient with type 1 diabetes is managed with an insulin regimen. The team selects a rapid-acting insulin to cover meals and a long-acting basal insulin for background control. Read the command. Which pairing is correct? Lispro aspart rapid mealtime, glargine detemir long-acting basal. Insulin preparations are classified by their onset and duration. The RAPID acting analogs, Lispro, aspart, and glulisine, have a very fast onset, about 15 minutes, and short duration, making them ideal for mealtime. Prandial bolus coverage, given right before eating to blunt the post-meal glucose rise. Regular insulin is short-acting, a bit slower than the rapid analogs. NPH is intermediate-acting. The long-acting basal analogs, glargine and detemir, provide a relatively PE-less, steady background insulin level lasting about 24 hours, used once daily for basal control. The correct answer is C. The basal bolus concept mirrors normal physiology. A long-acting basal insulin, glargine, provides a steady background, while rapid-acting boluses, Lispro aspart, cover the carbohydrate of each meal. The peak-wis profile of glargine reduces hypoglycemia between meals and overnight, so rapid analogs for meals, basal analogs for background. The Lispro aspart rapid and glargine detemir long-acting pairing is the correct one. What is the diagnosis? A 13-year-old boy presents with pain and swelling of the mid-thigh-femoral diaphysis for several weeks. X-ray shows a destructive lesion with an onion skin lamellated periosteal reaction. Biopsy shows sheets of small round blue cells. Cytogenetics reveal a T1122 translocation. Read the command. Diagnosis: adolescent, diaphysis, onion skin periosteal reaction, small round blue cells, 21122. Ewing sarcoma. This is Ewing sarcoma, a malignant bone tumor of children and adolescents, slightly younger and more often male than osteosarcoma. It characteristically arises in the diaphysis shaft of long bones, like the femur or the pelvis. The radiographic hallmark is an onion skin or lamellated periosteal reaction from layers of reactive bone. Histology shows sheets of small round blue cells, a small round blue cell tumor, sometimes forming Homer. Right rosettes. The defining cytogenetic finding is the TAT1122 translocation, creating the EWS-FLI1 fusion gene. The correct answer is E. The exam consistently contrasts Ewing with OSTE of sarcoma. Osteosarcoma occurs at the metaphysis, around the knee, shows a sunburst pattern in Codman triangle, and produces osteoid. Ewing occurs at the diaphysis, shows the onion skin reaction, is a small round blue cell tumor, and carries to 1122. Ewing is aggressive but responsive to chemotherapy. The diaphysiolocation, onion skin periosteal reaction, small round blue cells, and TW122 identify Ewing sarcoma. Which organism is responsible? A 30-year-old woman on broad-spectrum antibiotics develops thick white plaques on her tongue and buccal mucosa that scrape off, leaving an erythematous base, oral brush. A patient with AIDS, CD480, develops painful swallowing, esophagitis, from the same organism. KOH prep shows budding yeast with pseudohyphae. At 37 degrees C, the organism forms germ tubes. Read the command, which organism? Oral thrush, esophagitis in AIDS, budding yeast with pseudohyphae, germ tubes, Candida albicans. This is Candida albicans, a yeast that is a normal commensal but becomes pathogenic in certain settings. It causes oral thrush, white, curd-like plaques that scrape off, leaving a red base, classically with broad-spectrum antibiotic use, which kills competing flora, inhaled corticosteroids, diabetes, or immunosuppression. In immunocompromised patients, especially AIDS with low CD4, it causes esophagitis, painful swallowing, and AIDS-defining illness. Microscopically, Candida appears as budding yeast with P. pseudohyphae, and a key identifying feature is germ tube formation when incubated at 37 degrees. The correct answer is C. Candida's clinical spectrum is broad, oral thrush, esophagitis, vulvovaginal candidiasis, diabetics, antibiotics, diaper rash, intertrigo, and in neutropenic or catheterized patients, disseminated candidemia. The germ tube test and the budding yeast with pseudohyphae are the lab signatures. Esophagitis in an AIDS patient is most commonly Candida avius CMB or HSV ulcers. Treat with fluconazole or nystatin for oral thrush. The thrush and esophagitis with pseudohyphae and germ tubes identify Candida albicans. Which hormone regulates iron and how? A physiologist studies iron homeostasis. The body has no active mechanism to excrete iron, so absorption is tightly regulated by a key hormone made by the liver. In states of inflammation, this hormone rises, sequestering iron. Read the command. Which hormone regulates iron and how? Hepcidin blocks ferroportin when high, reducing absorption and trapping iron. The hormone is hepcidin, made by the liver, the master regulator of iron. Since the body cannot actively excrete iron, it controls iron balance at the level of AB absorption and release. Hepcidin acts on ferroportin, the channel that exports iron out of intestinal cells and macrophages into the blood. When hepcidin is hitched, it binds and degrades ferroportin, blocking iron export. This reduces intestinal iron absorption and traps iron inside macrophages, lowering serum iron. When hepcidin is low, ferroportin works and iron enters the blood. The correct answer is A. This explains anemia of chronic disease. Chronic inflammation via IL-6 raises hepcidin, which traps iron in storage macrophages and limits absorption, producing a functional iron deficiency with low serum iron but Higgs ferritin, even though total body iron is adequate. Conversely, in hemochromatosis, LOW hepcidin allows excessive iron absorption. Distinguish the players. Hepcidin, regulator, transferring blood transport, ferritin storage. Hepcidin, blocking ferroportin to reduce absorption and trap iron, is the regulatory mechanism. What is the diagnosis and the mechanism? A 25-year-old woman starts a new medication, a sulfonamide antibiotic, and 1 week later develops fever, malaise, and a painful rash with target-like lesions and widespread blistering. The blisters slough off, involving the oral, ocular, and genital mucosa, with epidermal detachment of about 8% of body surface area. Nikorski sign is positive. Read the command, diagnosis and mechanism. Sulfa drug, target lesions, mucosal involvement, epidermal sloughing, positive Nikolsky, Stevens-Johnson syndrome, TETN. This is Stevens-Johnson syndrome, and its more severe extreme, toxic epidermal necrolysis, TEN. It is a severe immune-mediated mucocutaneous reaction, most often triggered by drugs, classically sulfonamides, anticonvulsants, lamotrigine, carbamazepine, phenytoin, allopurinol, and certain antibiotics, or sometimes infections like Mycoplasma in children. The mechanism is widespread keratinocyte A, apoptosis leading to full-thickness epidermal, necrosis, and detachment. Patients have fever, a painful rash with target-like lesions and blisters, prominent mucosal involvement, oral, ocular, genital, and a positive Nikolsky sign as the epidermis sloughs. The correct answer is A. The distinction between SJS and TN is by body surface area of epidermal detachment. Less than 10% is SJS, more than 30% is TN, and 10-30% is overlap. It is a medical emergency managed like a severe burn. Stop the offending drug, supportive care in a burn unit, fluids, and wound care. The drug triggered keratinocyte apoptosis causing mucocutaneous epidermal necrosis and detachment, with target lesions and mucosal involvement is Stevens-Johnson syndrome TEN. Which nerve is lesion, and which way does the uvula deviate relative to the lesion? A patient has a brainstem stroke. On exam, when asked to say, the uvula deviates to the left, and he has hoarseness and difficulty swallowing, with loss of the gag reflex on the right. Read the command, which nerve and uvula deviation direction. Uvula deviates left, hoarseness, lost gag right CNX vagus, uvula deviates away from the lesion. The lesion nerve is the vagus. Cranial nerve, X, on the right side. The vagus innervates the muscles of the palate, pharynx, and larynx. Its branches elevate the soft palate and uvula symmetrically. When one vagus nerve is damaged, the palate on that side cannot elevate, so the intact left side pulls the uvula away from the lesion side. Here, the right CNX lesion makes the uvula deviate toward the left, the normal side. The vagus also supplies the larynx, hence hoarseness, and the motor limb of the gag reflex lost on the affected side. The correct answer is D. The rule to remember, the uvula deviates away from the side of a vagus lesion, opposite to the tongue, which deviates toward the side of a hypoglossal CN12 lesion. So tongue toward, uvula away. The vagus lesion adds hoarseness, recurrent laryngeal branch, and an absent gag reflex with CNX as the sensory limb, CNX as the motor limb. The right CNX lesion with the uvula deviating away to the left is the answer. How would you characterize this, and what distinguishes it from a major depressive episode or complicated to prolonged grief? A 60-year-old woman whose husband died 4 months ago has periods of sadness and tearfulness, especially around reminders of him. She maintains her daily functioning, sleeps and eats reasonably, and has moments of enjoyment with her grandchildren. She occasionally hears his voice, briefly, but knows he is gone. Read the command, characterize and distinguish from depression-complicated grief. Normal grief. Waxy swains, preserve function, brief perceptions of deceased are normal. This is normal grief, uncomplicated bereavement. Normal grief is an expected response to loss. The sadness comes in waves, often triggered by reminders of the deceased, but the person largely maintains daily functioning, can still experience moments of pleasure, and retain self-worth. Importantly, brief, non-pathological perceptions of the deceased, hearing their voice or sensing their presence, can occur in normal grief, and the person retains insight that the loved one is gone. Symptoms gradually improve over months. The correct answer is D. The distinctions are high yield. Major depression is suggested by pervasive, not wave-like depressed mood, significant functional impairment, feelings of worthlessness or excessive guilt unrelated to the deceased, and active suicidality, which warrant treatment. Prolonged and complicated. Grief is persistent, intense, disabling grief lasting beyond about 12 months in adults. These patients preserve functioning, wave-like sadness with reminders and intact insight at 4 months fit normal grief, which needs support rather than antidepressants. Which lysosomal storage disease is this? A 6-month-old infant presents with progressive irritability. developmental regression, peripheral neuropathy, and optic atrophy. The condition involves destruction of myelin in the central and peripheral nervous system. Enzyme testing shows deficient galactocerebrosidase, with accumulation of galactocerebroside and cytosine and characteristic globoid cells. Read the command, which lysosomal disease? Infant neurodegeneration with the myelination deficient galactocerebrosidase globoid cells, Krabbe disease. This is Krabbe disease, a lysosomal storage disease caused by deficiency of galactocerebrosidase galactosylceramidase. Without this enzyme, galactocerebroside and the toxic metabolite cytosine accumulate. Cytosine is toxic to oligodendrocytes and Schwann cells, causing destruction of myelin in both the central and peripheral nervous systems, a leukodystrophy. The result is a rapidly progressive infantile neurodegeneration, irritability, developmental regression, peripheral neuropathy, optic atrophy, and seizures. The pathologic hallmark is the GL-loboid CELL, a multinucleated macrophage engorged with undegraded galactocerebroside. The correct answer is C. The key identifiers are the enzyme galactocerebrosidase, the accumulated substrate galactocerebroside, and the globoid cells. Krabbe is one of the demyelinating sphingolipidoses alongside metachromatic leukodystrophy, aryl sulfatase, a deficiency accumulating sulfatides. Match each lysosomal disease to its enzyme and finding. Krabbe galactocerebrosidase press globoid cells, gopococerebrosidase, Tay-Sachs exosaminidase A, Fabryl alpha galactosidase A. The galactocerebrosidase deficiency with globoid cells and demyelination identifies Krabbe disease. What is the most likely thyroid malignancy? A 70-year-old woman presents with a rapidly enlarging, hard, fixed neck mass over a few weeks, with hoarseness and difficulty swallowing and breathing from local invasion. Biopsy shows highly pleomorphic, undifferentiated giant and spindle cells with frequent mitosis. The prognosis is very poor, with death often within months. Read the command, most likely thyroid malignancy. Elderly woman, rapidly enlarging fixed mass, local invasion, undifferentiated pleomorphic cells, poor prognosis, anaplastic thyroid carcinoma. This is anaplastic, undifferentiated thyroid carcinoma, the most aggressive thyroid malignancy occurring almost exclusively in the elderly. It presents as a rapidly enlarging, hard, fixed neck mass over weeks, and because it invades local structures, it causes compressive symptoms. Hoarseness, recurrent laryngeal nerve, dysesthesia, esophagus, and dyspnea or stridor trachea. Esophagus. Histology shows highly pleomorphic, undifferentiated giant and spindle cells with abundant mitosis. The prognosis is dismal, with most patients dying within months. The correct answer is E. The contrast across thyroid cancers by behavior is high yield. Papillary, most common, excellent prognosis. Lymphatic spread, follicular. Hematogenous spread, medullary C cells. Calcitonin, Min2, RET, and Anaplastic elderly, rapidly fatal. The rapidly growing, locally invasive, undifferentiated mass with compressive symptoms in an elderly patient and a grim prognosis identifies Wyvroid. What does this distinguish, and which gas is the classic example of each? A physiologist studies gas exchange across the alveolar membrane. For most gases, like O2 under normal conditions and N2O, equilibration between alveolar gas and capillary blood is reached quickly. For carbon monoxide, CO, blood content keeps rising along the whole capillary without reaching equilibrium. Read the command, what it distinguishes, and the examples. Perfusion limited, N2O, normal O2 versus diffusion, limited CO. This distinguishes perfusion limited from diffusion limited gas exchange. A gas is perfusion limited when it equilibrates between the alveolus and the capillary blood, airily along the capillary, so the only way to transport more is to increase blood flow via perfusion. Nitrous oxide. N2O is the classic example, and oxygen under normal conditions is also perfusion limited. It equilibrates by about a third of the way along the capillary. A gas is diffusion limited when it does not equilibrate. Its content keeps rising along the entire capillary because the gas keeps moving across as long as a gradient exists. Carbon monoxide is the classic example because it binds hemoglobin so avidly that the partial pressure gradient never closes. Correct answer is C. This matters clinically. Because CO is purely diffusion limited, it is used to measure the lung's diffusing capacity, the LCO, a value reduced when the membrane is thickened or destroyed, emphysema, fibrosis. And while oxygen is normally perfusion limited, in disease, thickened membrane, and fibrosis, or with exercise shortening transit time, oxygen can become diffusion limited, contributing to hypoxemia. Nitrous oxide and normal oxygen are perfusion limited. Carbon monoxide is diffusion limited. What is this, and how does it differ from a hypertrophic scar? A patient develops a raised, firm, overgrown scar that extends beyond the boundaries of the original wound and does not regress. Histology shows thick, disorganized bundles of TYPE3 and excess collagen. Read the command, what it is, and difference from hypertrophic scar. Collagen, beyond wound margins, recurs, hypertrophic stays within borders. This is a keloid, an abnormal, exuberant scar resulting from excessive collagen deposition during wound healing, with a disproportionate amount of TYPE3 collagen and overall excess collagen. The defining feature is that a keloid extends beyond the boundaries of the original wound, growing into the surrounding normal skin, and it tends not to regress into recuar after excision. Keloids are more common in darker-skinned individuals and at sites like the earlobes, chest, and shoulders. The correct answer is E. The contrast with the hypertrophic scar is the key point. A hypertrophic scar is also raised from excess collagen, but it stays confined within the original wound boundaries and often regresses over time. So the distinguishing rule is the wound margin. A keloid grows beyond the original wound and persists recurs. A hypertrophic scar stays within the wound and may regress. The scar extending beyond the wound margins with excess type 3 collagen and a tendency to recur is a keloid. What is the drug, its mechanism, and its signature toxicities? A patient with a testicular germ cell tumor is treated with a platinum-based chemotherapy agent. He is given aggressive IV hydration and amifostine, and his hearing and renal function are monitored. Read the command, drug, mechanism, signature toxicities. Platinum agent, IV hydration, amifostine, hearing renal monitoring, Cisplatin, DNA cross-linking, nephro-ototoxicity. The drug is Cisplatin, a platinum-based alkylating-like agent. Its mechanism is to cross-link DNA. It forms intrastrand and interstrand platinum. DNA adducts that distort the double helix, blocking DNA replication and transcription and triggering apoptosis. It is highly effective, notably in testicular and ovarian cancers. Its two signature dose-limiting toxicities are nephrotoxicity, acute kidney injury from tubular damage, and ototoxicity, sensorineural hearing loss, and tinnitus. It is also strongly emetogenic and can cause peripheral neuropathy. The correct answer is B. The protective measures in the question point to Cisplatin, aggressive IV. Hydration, with saline diuresis dilutes and flushes the drug to protect the kidneys, and amifostine, a free radical scavenger, is given as a cytoprotectant against the nephrotoxicity. Hearing and renal function are monitored throughout. Match the chemotoxicities once more. Cisplatin nephro-ototoxic, bleomycin pulmonary fibrosis, doxorubicin cardiotoxic, vincristine neuropathy, cyclophosphamide, hemorrhagic cystitis. The DNA cross-linking cisplatin with nephrotoxicity and ototoxicity, protected by hydration and amifostine, is the answer. Which organism is responsible, and the treatment? A 19-year-old college student presents with 2 weeks of low-grade fever, malaise, headache, and a persistent dry cough that is worse than his relatively mild exam and chest findings suggest walking pneumonia. Chest x-ray shows diffuse interstitial, patchy infiltrates that look worse than he appears. Cold agglutinins are positive. The organism has an old cell wall and is not seen on gram stain. Read the command, organism and treatment. Young adult, walking pneumonia, x-ray worse than exam, cold agglutinins, no cell wall, Mycoplasma pneumonia, macrolide doxycycline. This is Mycoplasma pneumoniae, the classic cause of walking pneumonia, and a typical pneumonia common in young, otherwise healthy people in close quarters, college dorms, military. The hallmark is a relatively mild clinical picture. Low-grade fever, malaise, headache, and a persistent dry cough. That is out of proportion to the diffuse, patchy interstitial infiltrates on chest x-ray. Looks worse than the patient feels. A classic associated finding is cold AGG glutinins, AGM antibodies that agglutinate red cells in the cold, which can cause a mild hemolytic anemia. The correct answer is B. The key microbiologic feature is that Mycoplasma has no cell wall. Its membrane contains cholesterol, and it requires special cholesterol-containing media eaten agar to grow. Because it lacks a cell wall, it is not visible on gram stain, and crucially, beta-lactam antibiotics, which target cell wall synthesis, are ineffective. Treat instead with a macrolide azithromycin or doxycycline, which target protein synthesis. The walking pneumonia with cold agglutinins from a wall-less organism treated with a macrolide or doxycycline is Mycoplasma pneumoniae. Which cell type is this, and what are its two key activating signals functions? An immunology student studies cells that kill virus-infected and tumor cells, without prior sensitization and without MHC restriction. These cells are activated when a target cell, down, regulates its MHC class, I missing self, and they can also kill antibody-coated cells. Read the command, which cell and its two activating signals. NK cells. NK cells, missing self-loss of MHC-I and ADCC CD16. These are natural killer NK cells, part of the innate immune system. Unlike cytotoxic T cells, NK cells kill virus-infected and tumor cells without prior sensitization and without MHC restriction. They do not need antigen presented on MHC. They have two main activating mechanisms. First, the missing self-recognition. Healthy cells display MHC class I, which sends an inhibitory signal to NK cells when a cell, down, regulates MHC-I as virus. Infected and tumor cells often do to evade T cells. That inhibition is lost and the NK cell kills it. Second, antibody-dependent cellular cytotoxicity. ADCC NK cells use their CD16 Fc receptor to bind antibody-coated cells and destroy them. The correct answer is A. NK cells fill a crucial gap. Viruses and tumors that hide from cytotoxic T cells by reducing MHC. I make themselves targets for NK cells. If you don't show your MHC-I, the NK cell kills you. They kill via perforin and granzymes like CD8 T cells and release interferon gamma. They are enhanced by IL-2, IL-12, and interferons. The innate cytotoxic cell, activated by missing self and by ADCC through CD16, is the natural killer cell. Block 20 is done, 400 questions simulated. Let's review the 5 biggest traps from this block. Trap 1. Rapid shallow breathing has the same minute ventilation but much lower alveolar ventilation because the fixed dead space consumes a larger fraction of each small breath. Slow, deep breaths are more efficient. Trap 2. Cardiac tamponade compresses the heart, impairing diastolic filling. The Beck triad, hypotension, distended neck veins, muffled heart sounds, plus pulsus paradoxus and electrical alternance points to it. Treat with pericardiocentesis. Trap 3. Both involve copper transporting ATPases. Menkes is ATP7A causing copper deficiency in kinky hair from deficient lysyl oxidase. Wilson is ATP7B causing copper overload. Trapped foal with a vagus nerve lesion, the uvula deviates away from the lesion side. Contrast with the hypoglossal nerve, where the tongue deviates toward the lesion, tongue toward, uvula away. Trap 5. Mycoplasma pneumonia has no cell wall, so it is not gram-stainable and beta-lactams do not work. Walking pneumonia with cold agglutinins is treated with a macrolide or doxycycline. 20 blocks. 400 questions of train reasoning. 2/3 of the way through the full set. Train process, not memorization. StepLogic. Learn how to think, not memorize.